Bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Hello, good morning again, and welcome again to ARI 2024 from the sunny day in Alicante. We have an understanding top-class session now about cornea, about complicated cornea. José Luis Güell and Jorge Aleo del Barrio will lead. And Jorge, you start with the introduction to this session.
Thank you very much. For me and for Dr. Well, it's a pleasure to have these great panelists and speakers. They are absolutely famous all around the world. We have Professor Meles, Guillermo Amezcua, Berthold Seitz, and Mario Nubile. I'm sure we're going to learn a lot from them, and I'm pleased to hear and be able to hear them. So we're going to start with Dr. Meles with his lecture about new concepts on corneal physiology and Fuchs endothelial corneal dystrophy. Please, Jared, you can start.
Thank you so much for having me at your meeting. I always enjoy the enthusiasm of Professor Aleo and his group, and I hope you're going to be enthusiastic about this little theory from Rotterdam as well. In the interest of time, I'm going to skip a few parts, but there is a handout available through the QR code that is also displayed on each slide. The key problem is that after being in corneal surgery for about 20 years, I still do not really understand why a transplant is effective, and that clinical observation does just not agree with the literature. And for that reason, what our theory entails is that you may have a different system for the hydration of the cornea in a horizontal way to feed the cornea for the nutrients and all things that are important for the cornea to survive, and a vertical organization of the hydration for the imbibition pressure of the cornea, that is the corneal transparency. The second question would be whether Fuchs dystrophy is an endothelial disease or a problem within the stroma. The third thing is the relationship between Fuchs dystrophy and primary open-angle glaucoma. And if we understand maybe the problem in the stroma within a Fuchs dystrophy, maybe it opens the door to understanding primary open-angle glaucoma. In corneal surgery, if you have an endothelial disorder, it's most often either a bullous keratopathy or a fused dystrophy. And in the bullous keratopathy, things are pretty much straightforward. You see that the cornea is swollen. If you look with specular microscopy, you see the endothelial cell layer a little bit blurry, but the cells are there, and there's just a disconnect between the amount of influx, at least that's the theory, the passive inflow of aqueous into the stroma, and the amount that can be pumped out again by the endothelium. But in fused dystrophy, you have a completely different picture. There you can see the endothelial cells pretty crisp. The cornea is about 600 microns, maybe 650, but not 1,000, not 1,500. And you have these large areas that seem to be devoid of cells or where the cells have thinned. So it would be difficult if you have endothelial cells that are not present to explain the image of a fused dystrophy, that there is no corneal swelling despite the fact that the corneal endothelial cells are just absent. If you look a little bit closer at the cornea, you may see, especially in decompensated or borderline decompensated corneas, these refractive sheens, watery films that go in a horizontal way across the cornea. Another indication may be that the cornea seems to survive even after years and years, decades after trauma. The cornea is not going to melt away, even if the endothelium is not present, despite the fact that all our tissues need perfusion to survive. So our theory would be that there is a horizontal perfusion of the cornea from the vascular arcade at the limbus, and there is a vertical organization for the static hydration of the cornea, for the imbibition pressure. So what do we know? And the key thing is, what is the role of the endothelium in corneal hydration? And what do we know from clinical observation? Well, the first thing is that the endothelium seems to be at the interface of two pressure systems. The intraocular pressure of about 20 millimeters of mercury and the inhibition pressure, the negative suction force inside the stroma of about 40 millimeters of mercury. If you do an endothelial keratoplasty, it is effective from a clinical point of view, but at the same time, it's very difficult to explain that you have an almost normal inhibition pressure, hardly any corneal swelling, so to speak, in the absence of corneal endothelium. Now, if you look at the inhibition pressure, what always strikes me is that this is probably an image that you're familiar with. This is a DMAC graph that is detached in this particular area, and overlaying the detachment, you can see that there is corneal edema. So the inhibition pressure up here is 0. But at the same time, in the very center, the cornea is clear, the thickness, the pachymetry is normal, and the inhibition pressure should be about 40 millimeters of mercury. So there is a huge difference in pressure over this small area up here. It's 40 up here, 0 up here. Same thing, for example, with a decompensated PK graft in the keratoconus cornea, where there is a huge difference in inhibition pressure going from 0 to 40 millimeters, also over a very short distance. So clinical observation would suggest that there is a very refined distribution of mucopolysaccharides in a vertical way, with an almost one-to-one correspondence of the molecules with the endothelium. And if you have a almost normal inhibition pressure in the absence of endothelium, there are basically two conclusions. Either fused dystrophy is not a corneal endothelial disease, or the inhibition pressure is controlled by a different mechanism inside the stroma. The theory in the literature also does, maybe to some extent, not really add up, at least not agree with the clinical observation, that the theory is that you have endothelial cell death in fused dystrophy through apoptosis, and you have the formation of guttae as a replacement. But for example, if you have a phaco tip that damages the endothelium at 12 o'clock, it's not like it's going to heal up with massive formation of guttae in that area. So all in all, there must be a very refined structure of the mucopolysaccharides in the stroma that may be responsible for a secondary response by the endothelium that we perceive from a clinical point of view. It's almost like the stroma must be involved somehow in fuchs dystrophy as a disease. And if so, then it would stand to reason that if Fuchs dystrophy would not be primarily be an endothelial disorder, but rather be a disorder of the mucopolysaccharides and a inhibition pressure that is too high, so to speak, so you basically have a corneal glaucoma, it may open the door. If you just consider reframing the disease as a stromal problem, it may open the door to also looking for a solution or a treatment in that particular area. And as a secondary benefit, if you would have the feeling that if you understand why the inhibition pressure is too high in the stroma in the Fuchs dystrophy, it may also shine a light on understanding primary open-angle glaucoma. Well, I hope it's all making sense to you. Thank you so much for your attention. And if you have better ideas or criticism, I'm completely open to it. Let's have a discussion about it. Thank you so much for your attention.
Thank you very much, Jerry. It has been a pleasure. Later, we'll have time for the discussion. So now we're going to head with Guillermo Amezcua and his talk about advances in the treatment of fungal corneal infection.
Hi, how are you? I'm Guillermo Amezcua, cornea surgeon from the Bascom Palmer Eye Institute, and excited to share with you some of our experience in the management of fungal keratitis. I appreciate the invitation to share our experience here at this great virtual meeting. We do see a significant amount of fungal infections here in South Florida. It's not a very common cause of infectious keratitis in the United States, but it being in South Florida with the tropical weather is something that we unfortunately see frequently because these cases can be difficult to manage. It is a common cause, like you can see here, that our most common is gram negatives, but in green, this is a pie chart of the number of fungal keratitis that we see at the Bascom Palmer Eye Institute in some part of the world, like in South India. It may be the most common cause of infection, and it's a very difficult etiology to treat. Most of the cases that we see are filamentous fungi. We do see some cases of yeast, such as Candida parapsilosis or Candida albicans, but by far Fusarium keratitis is the most common. Historically, and still true in many parts of the world, trauma, occupational trauma, agricultural trauma, by far the most common risk factors, previous surgery, chronic use of steroid drops. But in our area of practice, the most common cause is, or risk factor is contact lens use, especially soft contact lens use. In the patient's history, a lot of them refer using soft contact lenses. Not many patients with fungal keratitis related to scleral lenses or rigid gauze permeables or hybrid. Most neurotrophic cornea secondary to herpetic disease is another important part in the history. Exposure keratitis, chronic conjunctivitis. The clinical presentation can vary. It has a more indolent presentation than some of the gram-negative bacterial keratitis or streptococcus keratitis. Usually the patients have a history of days to weeks of this waxing and waning infiltrate that's not getting better with topical antibiotics. They can have feathery margins, satellite lesions, in some cases, small hypopions. The conjunctiva is not as injected as in some of the cases of gram-negatives. And you can see here in some cases, when you start seeing pigment in the lesion of the infiltrate, be suspicious of a fungal keratitis. This is a curvularia pigmenta filamentous fungi. It also will depend on what stage of the disease you're seeing the patient. Patients can look very different as if you in time. So just be aware and get a good history on these patients. if you just go by clinical diagnosis, it can be a very challenging condition to diagnose. We know this from the data from the group at Baylor, where they show that if we just base it on our clinical skills, we're not going to do very well. This may change soon. Dr. Travis Reed at the University of Oregon is working on algorithms with artificial intelligence, and he's already showing us that machine learning is much better than expert clinicians with using slit lamp photography. So artificial intelligence really making a positive impact in the management of these patients. If you have access to laboratory diagnosis, please do. This can help significantly to speed the time of diagnosis and improve the patient's outcome. So either the use of gram stains, GEMSA, or KOH can make a significant positive impact. 91% of our smears correlate with our culture results. So very commonly in daily practice, I will scrape the cornea. I will walk this to our microbiology lab that we are very lucky to have it next to our building. And we can get a diagnosis right there and save a lot of time. But if you have access to confocal microscopy, please consider this in your challenging cases of microbial keratitis. In those cases that are not responding to the standard medical care, the patients that have risk factors, if you're suspicious for fungal keratitis, don't delay. Send the patient for confocal microscopy. It is being shown to be an excellent tool in the management of these patients. Some of these patients will continue to progress, and you're suspicious for fungal keratitis, but you don't have a diagnosis. So nowadays, molecular diagnosis is a reality, either by using DNA or mRNA. There are different probes that we can use. Nowadays, you can have probes that have 20, 25 microorganisms that you can diagnose on just one sample. So I think this is, well, not the future, this is a reality that will continue to get better, and we will decrease the time. You have to be aware there are some false positive diagnoses with this. The good thing about molecular diagnosis is that you can also learn more about the subtypes of the species and see how some of the species have genes for resistance, and this is why some of them do better than others with medical therapy. And we know that some of the fusariums are more aggressive, and you end up early on with molecular diagnosis, knowing which ones are going to end up in a penetrating keratoplasty. Corneal biopsy is something that can be used in fungal keratitis to get the correct diagnosis. We send half the tissue to microbiology and half to pathology. And the treatment, there are different options. Unfortunately, not many commercially available options. Many of these are compounding medications that need subspecialty pharmacy, and this is why some of the delay in the treatment of these patients. Natamycin used to be commercially available, not anymore in the United States. And this is some problem because it's not just not easily commercially available, but it's also expensive, and it affects the patient's outcome. So normally we will do scrapings. We can do confocal microscopy. If we're suspicious for a filamentous fungi and we have high level of data that it may be a fungal infection, we will start treatment with natamycin, not with voriconazole, based on the mycotic ulcer treatment trial data. If we are dealing with the yeast, we will use amphotericin B. The mycotic ulcer treatment trial was an excellent prospective randomized control trial by the group of Dr. Tom Liedman and Jennifer Rose at the Proctor Foundation, also with the leadership of Dr. Prashna at Arabian Eye Hospital, where these patients were recruited and treated. Basically, this trial showed us that natamycin was superior to topical voriconazole in the fusarium patients. They also show us that voriconazole patients did worse than natamycin, and systemic voriconazole can be something that we can use in some of the subspecies of fusarium. Not many cases of aspergillus to have strong evidence to know what would be the best management in this trial. So when patients are not responding, we have to have algorithms in our practice, and we have our own advanced compolymer. There are other excellent algorithms here, like the one of Narmatra Sharma, specific for fungal keratitis, that I invite you all to read. she and her group showed that by following this algorithm, you can get a high a percentage of medical cure without needing a penetrating keratoplasty. And last, we've been concentrated the last number of years. This is the first publication in 2014, 10 years ago, when we got interested in using a different photosensitizing agent, rose bengal, activated by a green fluorescent light, because our results with riboflavin and UV light were not very good in vitro. So we show that we can kill in vitro many of the fungus that we normally encounter in clinical practice. We have done a significant amount of research in other organisms, such as Pseudomonas, multi-drug resistant Pseudomonas, and Staphylococcus, and Mycobacteria, and Nocardia, etc. And all this is published and available. Most of these papers are open access for you. Our efforts in fungal keratitis were now studied by a randomized controlled trial, also from the group of Arabin and the group of Proctor Foundation, in collaboration also with the group in Sao Paulo. The trial recruited 330 patients. The trial is closed. It closed back in April. The results will be released soon. We're waiting on the follow-up of some of the last patients, and the data will be presented at the World Cornea Congress in Washington, D.C. So in conclusion, be aware of the microbiological epidemiology in the area that you practice. Get microbiology lab support every time you can. Early diagnosis can make a difference. The treatment of fungal keratitis can be long, and some of these patients, when we catch it late in the game, when the infection is past the deep in the cornea stroma, this becomes a surgical intervention, a surgical treatment. So natamycin is still a first line of therapy for filamentous fungi, and topical steroids are contraindicated in this condition. So photodynamic therapy may play a role. We'll know the results in the near future. Thank you very much for your attention. Thank you very much.
Thank you very much, Guillermo. So we're going to move more forward to the talk from Professor Seitz about, is PKP a timeless procedure?
Hi, how are you? I'm Guillermo Mezcua, cornea surgeon from the Bascom Palmer Institute.
Hello, everybody from Germany. Dear chairpersons, ladies and gentlemen, in the next few minutes I would like to convince you that PKP is a timeless procedure, but nowadays the technique ranges by far beyond the exchange of two corneal buttons. Corneal transplantation is the oldest, the most frequent and most successful transplantation in humans. The first penetrating graft dates back almost 120 years. In Germany, we perform more than 9,700 keratoplasties with an increasing tendency. In our place in Homburg-Saar, the number of keratoplasty has increased by tenfold over the last 15 years. We perform by far the most penetrating grafts with around 100 emergency keratoplasties. In Germany, the absolute amount of penetrating grafts stays about the same over the last years, but the absolute amount of posterior lamellar grafts increased dramatically. Overall, over the last 5 years, the proportion of posterior grafts is around 2/3 of all keratoplasties. In Germany, 99% of posterior grafts are performed as DMEC. Let's now first talk about the timeless indications for PKP within and beyond routine. We have principal indications which are optical indications, but also high-risk keratoplasties and therapeutic indications. Timeless indications for PKP with or without cataract surgery, from my point of view, are dystrophies which affect all layers of the cornea, higher astigmatism after PKP, advanced keratoconus, especially after corneal hydrops, keratoglobus or pellucid marginal degeneration, unstable corneas, aphakia, here we always use a Flieringer ring, autologous keratoplasties, infectious keratitis, and plaque excision. This is macular dystrophy before and after excimer laser PKP. Histology shows us that the acid mucopolysaccharides reach from the epithelium over the stroma down to the endothelium. Here, repeat keratoconus after small decentered graft. In this case, we do a repeated excimer laser PKP with optimal centration and optimal 8.5 millimeter graft size. This is high irregular stigmatism with major host stromal thinning adjacent to a very small transplant. There is no indication for a DMEC after PKP, but we need a repeat excimer laser PKP with optimal centration and graft size to excise this hinge effect completely. In corneal hydrops, we never do a keratoplasty during the acute stage, but we use what we call deep stromal Moraine sutures. Moraine sutures help us to reduce corneal edema even the first day after suturing, and after 6 weeks we have a stable scar. And then we can do excimer laser PKP after Moraine sutures. Here we have the laser procedure. We always perform an iridotomy, then the first cardinal suture at the 6 o'clock position, then the second at the 12 o'clock position, 8 cardinal sutures, and then the double running suture according to Hoffman. We always bury the knots in the stroma and use a placido disc. In case of bilateral keratoglobus with extreme thinning and nuclear cataracts, we can perform a central corneoscleroplasty as an open sky triple procedure, 11.5 and 12 millimeter grafts. In case of ulcerative necrotizing stromal keratitis with decimetocele of herpetic origin, we can perform a round excimer laser PKP à chaud, and here these vessels typically regress. In case of eccentric mini perforation, we can do an eccentric mini keratoplasty. In case of a central corneal scar after perforated injury, we can rotate this scar to the periphery by ipsilateral autologous rotational keratoplasty, of course a penetrating procedure. If the patient has one bad cornea and good retina and the other eye has a good cornea and a bad retina, we can use the patient's own cornea in the sense of a contralateral autologous penetrating keratoplasty. In case of elliptical acanthamoeba ulcer, we can use an elliptical excimer laser keratoplasty. You see that the cysts are close to Decimet's membrane, so we would never perform a DALT, but always a penetrating graft in this case. This is ulcerative necrotizing acanthamoeba keratitis 4 months after conservative treatment with severe neovascularization and deep-reaching disease. This is the situation 6 weeks after PKP, corneal cryocoagulation, single sutures and systemic immune suppression. The cornea is clear. In case of Fusarium solani keratitis, which tends to deteriorate very fastly over a few days, we have to perform quickly a large penetrating keratoplasty, which can be kept clear with antifungal therapy for more than 6 to 8 weeks and systemic immune suppression. This is the case of a wide limbal rheumatoid melting with perforation. Here we perform a peripheral semilunar tectonic corneoscleroplasty using 2 trifines with different diameters. We measure the distances, then we produce the transplant on the corneoscleral button in an artificial anterior chamber. We use a lot of single sutures to fixate this graft in the recipient bed. In case of traumatic epithelial implantation cyst after repeat alcohol injection, we perform a block excision and peripheral tectonic corneoscleroplasty simultaneous with phacoemulsification and capsular tension ring. Here you can see the in toto excised epithelial implantation cyst as a block including ciliary body, iris, cornea, and sclera. Now a few technical details to improve the outcome of penetrating keratoplasty. We always perform a sterile donor tomography in our eye bank, and by doing this we can measure the curvature of the anterior cornea and the posterior cornea and the corneal thickness, so we avoid the transplantation of a donor with keratoconus or a donor after LASIK or after PRK. In the open eye situation, we prefer general anesthesia with controlled arterial hypotension and maximal relaxation. We never use mivacurium but atracurium as a muscle relaxant. The horizontal positioning of head and limbus is crucial. Sometimes this may be difficult in the special case of morbus Bechterew. Since more than 35 years, we use the method of excimer laser trephination for donor and recipient trephination with good astigmatism and good visual acuity. The donor mask has 8 orientation teeth, and this fits like a key in a keyhole in the recipient mask with 8 orientation notches. The major advantages of this orientation teeth is the exact position of the second cardinal suture, exactly 180 degree opposite of the first one. Severe keratoconus is one of the main indications for excimer laser PKP with metal masks that are placed directly around the cone, resulting in round openings and perpendicular cut edges. Also in panel-seat marginal degeneration with excessive thinning, we can get good trephination, but certainly single sutures are necessary. We always use the Schwinter Maris 1050 RS for this in the pseudo ring profile. We always perform a peripheral iridotomy at the 12 o'clock position to prevent Uretz-Savalia syndrome, persisting wide pupil. And at the end, we perform the double running cross-stitch suture according to Hoffman in normal risk grafts. I just met Professor Hoffman at the age of 86 at our German Congress in Berlin. And our colleague Dr. Suffo introduced the Homburg cross-stitch marker. It has the shape of a 7 and it allows surgeons to perform a good double running cross-stitch suture. We have 2 points where we know exactly how to stitch in and where to stitch out with a needle, and this can be done a second time. And in 6 weeks' time, people come back with such double running cross-stitch sutures in quite a monomorphic shape. This brings me to the end of this short talk. Question was, should we still do PKP? Yes, of course. There are timeless indications for PKP within and beyond routine, even in the lamellar era. The excimer laser trephination has been performed from our group for 35 years to improve visual acuity. Sterile donor tomography in the eye bank prevents the transplantation of a keratoconic cornea, and the Homburg cross-stitch marker facilitates double-running cross-stitch sutures. Thank you very much for your attention, and I wish you a good Congress.
Thank you very much, Prof. Seitz. So now we're going to proceed with the last talk of this session before the debate, that is by Mario Nubile, Customize the Smile Lenticles in the Treatment of Corneal Ataxia. Thank you, Mario.
Good morning, everyone. It is a pleasure to participate to this excellent online congress. The title of this presentation is Customize Smile Lenticles in the Treatment of Corneal Ectasia. The basic principle of corneal reshaping in ectasia is the use of implanting intrastromal tissue to alter and modify the curvature of the cornea rather than changing the stroma, either with a DALK or APK. This can be achieved by the use of allogenic corneal stromal tissue implantation, which is a technique that pairs with the possibility of using synthetic material like the intracorneal stroma brings. Actually, there have been many kind of proposals of tissue implantation, as you can see here in this systematic review and meta-analysis, in which different kind of lenticles coming from different sources, including RELEX or KLEX, surgery for myopia has been adopted. Different shapes means planar lenticles, means negative meniscus lenticles like stromal lenticle addition keratoplasty, Bowman's layer transplantation with the retainment some part of the stroma, CARES, which is the use of allogenic stromal ring segment, or donut lenticles. Each of the techniques has some utility and has some advantages, but carries on also some disadvantages as compared to the others, as you can see in the slide. One of the options that we have been fully investigated is the proposal of SLAC, which is actually stromal lenticle addition keratoplasty, and the basic concept is the implantation of a negative meniscus shape lenticle that is thinner in the center and thicker in the periphery. So the geometry which is opposite of that of a myopic lenticle to reshape and stabilize the corneas in eyes with either progressive or non-progressive keratoconus. The implantation of a negative meniscus-shaped lenticles leads to the flattening and regularization effect in an ectatic cornea through the mechanism of the arc shortening effect and the tissue addition effect. And as you can see here, the tissue is simply implanted into the recipient eye through a pocket that is created in the stroma by the femtosecond laser. Femtosecond slag was successfully used in the treatment of advanced keratoconus. As you can see in this video and in the clinical results of this case series published some years ago, the lenticle is produced by sculpting the tissue, the stromal tissue, with the use of femtosecond laser from donor cornea of eye bank tissues. Then, once the lenticle is isolated and separated, a pocket is created into the anterior stroma at average depth of 130 and 140 microns in the recipient eyes, and thereafter the lenticle is inserted into the stroma and unfolded and centered according to the apex of the cone of the single patient in a very easy maneuver, and the surgery is completed easily under topical anesthesia. Postoperative wound healing is generally uneventful, and tissue transparency is gained after a few days and maintained throughout the entire follow-up of 24 months, as you can see here. Regarding the refractive and visual effect of this kind of implantation, what you achieve is a reduction of the spherical equivalent through the flattening that you obtain, so reducing the myopic component, and also reduction of astigmatism, and increase in best corrected visual acuity. You see here one example in which a keratoconus treated by the slag technique achieves central flattening, as you can see also in the differential map, and improvement of best spectacle corrected visual acuity and refraction over time. With respect to epithelial and stromal remodeling following slag implantation, it is interesting to note that the flattening of the apex of the cone is correlated with the increase of the epithelial thickness, which is typically thin at the apex of the keratoconus, as you can see in the slide. And this is also associated with the increase of the stromal thickness, which is dependent on the tissue implantation effect. And together, those effects implies the significant rethickening in the total corneal thickness, and this is achieved while maintaining the desired effect of reducing the anterior curvature, so flattening the apex of the keratoconic cornea. Interestingly, long-term follow-up up to nearly 5 years showed that the long-term flattening effect of the cone apex is maintained throughout the follow-up, and also the stromal component and the epithelial component of the rethickening is very stable. And OCT analysis showed that the lenticle shape is maintained throughout time without remodeling or modification of the relative thicknesses. Recently, we have investigated the possibility of treating eccentric keratoconus by customizing the lenticle shape, and this was achieved either by customizing the shape of a planar lenticle or negative meniscus lenticle, as you can see here, produced in an ex vivo eye bank model using the excimer laser ablation to modify the lenticle shape. Starting from donor corneas, 4 different types of shapes lenticles were produced. Type 1 and 2 are the regular planar and negative meniscus shape, while type 3 and 4 are the customized version of these lenticles with the curvature and thickness change in parameters represented in table 2 on the right side of the slide, as you can see. The implantation of the lenticles should be performed according to the relative position of the cone apex, and also the tissue should be marked in order to guarantee the correct alignment of the implant. But as you can see in the table, the different shapes of the lenticle produces different kind of corneal reshaping. And just to summarize, the customer Customized planar lenticles showed the best regularization effect and are ideal for eccentric keratoconus, while the customized negative lenticles show the best flattening effect of a corneal apex, which are then ideal for paracentral keratoconus. What is coming for the future application is the fully automatic tomography-guided lenticle customization in order to reshape the specific cornea of each patient according to the morphology of the preparative tomography, and producing customized lenticles which are perfectly fit and tailored according to the size and shape of dimension of the cone apex of each single patient. Future application might include bioengineered and customized stromal lenticles. So drugs contained into microparticles can be embedded in decellularized lenticle, and this can be an efficient method to achieve greater concentration of drug substances for extended period of time to treat diseased corneas. And also, we need to keep in mind that there is a large waste of stromal tissue when performing femtosecond laser calyx surgery, and smile-derived lenticles from over 10 million up to date, as in 2024, can drastically improve the shortage of transplantable corneal stromal tissue, and this tissue can be stored in eye bank, to which we need to work on. Customization then of stromal lenticle is a crucial need to treat the majority of patients affected by keratoconus and also by other corneal diseases. Thank you very much for your kind attention.
Thank you very much, Mario. So now we're going to proceed with the discussion. So please, Dr. Well, I give you the lead.
Well, thank you, Jorge. We can lead together. We're co-moderators, but let's go in another way. Perhaps we can start with Gerrit. And Gerrit, as always, your suggestions are quite provocative. Which I like that. I like that. You're getting older, but you have the same spirit. So, so from a clinical point of view, I think that might be you're right. But I have some concerns regarding what we have or what we know up to now regarding genetics, because despite of the variability, of course, of the genetic maps in Fuchs, and then we know that this is not a single genetic disease, but a number of genes are involved in different groups of Fuchs. Most of these genes are focused on mesenchymal and on endothelium. So in some way, what we know up to now, from a genetic point of view, would not agree on your very well understandable clinical observation, no? So do you have an explanation or a suggestion or possible?
Well, you know, the first thing I would want to say, it may just be that it is completely wrong. You know, that the whole theory is not whatever true, but even if it would be 10% or so, there would be 10% of truth in it, you know, it would maybe already generate some discussion or so, because as I also said in my presentation, some things just, you know, purely from clinical observation do not make sense to me. If it would be true that your endothelium is more or less gone in Fuchs endothelial dystrophy, I mean that you have these big holes or very thin cells, I mean, how would you explain that there is not massive stromal swelling? On the other, and what you're saying is also like, I mean, you can also come up with all kinds of things that point towards the endothelium, or you may be looking at, you know, a subgroup of patients that is sensitive maybe to, how do you say it, if they have a problem in the stroma, maybe we all have the same problem in the stroma, but only in those patients it's going to show as Guttae and as a Fuchs dystrophy. I have no clue. But But the interesting thing is that, you know, if you put all these clinical observations together, that I truly do not understand what we're doing with corneal transplantation, just to provoke. But it's also, you know, to throw out the ball and to generate some discussion. And what I also said, if you have a better idea, I'm completely open for it. You know what I mean? It's
no, absolutely. And you have created this kind of discussion because I think it makes sense, especially in some subgroups of eyes. In some others, I think that definitely from what we know from the gene evaluations, it should be an endothelial disease, but might be is like an end stage. So this secondary corneal edema might be an end stage of different problems, and some of them might be a stromal problem. So yeah, might be. Let's see. Let's follow that discussion. Jorge, perhaps we move with the other speakers because I found Amezcua lecture very interesting. My question, if he was there, but if not, any one of you can respond to that or their opinion, is that because I also think that now in our area, fungal keratitis is mostly related with soft contact lens use. Of course, still some other clinical situations such as trauma, but the relation with soft contact lenses is quite common. And sometimes in the early beginning, you would need a high level of suspicion, in the same way that acanthamoeba is also quite frequent in contact lens users. And again, you also need a high level of suspicion. The question would be, would you consider in those cases where you have no clear clues that this is a bacterial infection, to prophylactically start with chlorhexidine and with natamycin in those cases where you see a suspicious infection, but from the beginning as a prophylactic treatment? Would you think that this would be something that we should consider? So I don't know, Juan, you can start responding, because unfortunately Guillermo is not here.
Using natamycin directly without any positive culture, I will not consider it. Maybe chlorhexidine, which has a broad spectrum and can also kill bacteria until you have the positive culture, maybe it could be a good rationale to use it. Maybe not directly natamycin. Okay, so this is my opinion, or iodine, something like that.
Bertrand?
So I think we do all the time when patients come in, we do the confocal microscopy first, and we have some specialists, not me, but we have some specialists who can really distinguish the railroad pattern for the fungus and of course the double walled cyst for the acanthamoeba. And we also removed, after the confocal microscopy, the epithelium and send it directly to the PCR for fungus and for acanthamoeba. And I would also agree with Juan that I would never start anti-acanthamoebic or antifungal treatment if there is no deterioration, or if we have not at all any suspicion. Only if we have a progression, of course, then we go deeper, and then we can add this.
Yeah, I understand your point, Belfort, but my question was more related for those situations where these patients go to not so very well equipped institutions, and that perhaps a chlorhexidine or an antiseptic prophylactic treatment together with the antibiotic until you receive the results from your culture might be something that we might consider.
You can do the Labacept, for example, you know?
Yeah. Yeah, in the other, Alberto, of course.
A question for you, Jose. I recognize that I use prophylactically chlorhexidine when I'm not sure if an acanthamoeba or a fungal keratitis is what I have in front of me. But I'm not sure about the concentration of this in these cases. Do you use 0.02% or do you prefer higher concentration, that's 0.2%?
No, I for a prophylactic treatment, I must say that I always use chlorhexidine when I have a suspicion. And in fact, in any infectious keratitis on a contact lens user, I always use without or with or without suspicion chlorhexidine. And I use on the lower concentration, 0.02, 6 times per day. Okay. That's my standard. The other point is that, and now I wasn't aware of that natamycin was not available also in US. It is not available, at least in our country. So how do you deal with that? So in the Netherlands, in Germany, in Italy, how do you deal with natamycin? How you provide? Mario, you are mute. You are mute, Mario. You're still mute. You can use your fingers.
Yeah. We cannot hear you. Maybe we can, meanwhile, ask Berthold while Mario sorts it out.
So how do you, Jorge or Alberto or Juan, how do you obtain your natamycin, if you do?
So usually what we do is, because in UK, as far as to my knowledge, is still available. The problem that I find is that many times at the time I was getting the natamycin, it was too late. So I always start with voriconazole in these cases and try to get the natamycin, but at least on my experience that I'm not in a public hospital, many times at the time I receive the natamycin becomes too late. So what I do, once I receive that natamycin, I store it for the next patient. So at least the next patient will benefit from the fact of having that natamycin stored. But it's true that many times, since our rate of fungal keratitis is low, many times it becomes outdated and then we are again on the same start point. So it really becomes a problem, the fungal keratitis today, outside the voriconazole, that according to Dr. Amezcua's presentation, is probably not the way to go, but the way we are forced to go.
Yeah, probably you, Juan, and Alberto are doing the same. No, I stored a couple of free samples at IMO and wait. And yes, sometimes you are 1 year without any case, and sometimes you have 3 cases in 15 days. No, but
I totally must have it, and we always start with a voriconazole 2%. I think mostly they use 1%, but I think 2% is very well tolerated and has some more effect. But I surely agree that in Fusarium, voriconazole alone does not help.
Yeah, that's a problem. That's the main.
Can you hear me now?
Yes, now.
Okay, sorry. I need to solve the problem of the audio, but it was tricky, but it's fine. Just to answer about Italy. So I totally agree on the fact that we shouldn't use natamycin if we have no certainty of culture-proven or even confocal microscopy imaging. But chlorhexidine, for sure, it's one option. And regarding the availability of natamycin, if we don't have ready the natamycin, because we can order now from the internet, even in countries where the drug is not available, which is a good option. So we have to suggest to this clinician that where they cannot find ready available in their pharmacies, you can order on the website, and under your responsibility, the drug is fully dispensable, which is the case in Italy, because we have no commercialization of natamycin, but you can have the US product or the Indian product. I don't say the names. And for voriconazole, I agree with Berthold. That is a very good option, the galenic preparation of voriconazole, either 1 or 2% in case of culture-proven or confocal-proven fungal keratitis.
But may I add something about HSV?
Yes?
We looked at 2,000 specimens that we the excised corneas, and we saw that in fungal keratitis, positive HSV PCR in 5% of all cases. So typically when we have a proven fungal keratitis, add some antivirals, Virgan, Ganciclovir 5 times a day or something, just to be on the safe side.
Yeah. Bertolt, now that you're talking, let's move to you,
Mario.
Tell me.
Very quick, Mario. So you ask the patient to buy it, or the hospital does buy it? Because if you probably here, if we ask the hospital to buy it, they are going to look at you very rarely, the patient. And how long, in your experience, takes more or less? So they go online to an Indian company and then they receive it in what is time frame, more or less, in your experience?
Okay, so usually the hospital prepares the galenic preparation of voriconazole, but usually they don't buy the natamycin. The natamycin needs to be bought by the patient itself. We have the Vatican in Italy. The Vatican pharmacy is very special, so they can get every drug from every part of the world and get collected in Rome. And from Rome, then it's very easy to. So we have a special situation through the Vatican pharmacy.
Oh, okay. So then any of us being Catholics can use it, not the Protestants, no? Okay, let's. We have 5 minutes left, so two questions. One for Professor Seitz. So two questions, no, or any more if you want, of course. But my question to you, Bertolt, is that how often do you need to adjust the running during the following 12, 20 months after the surgery? Because those, as me, who are using interrupted sutures to adjust and to control for the next 2 years, the astigmatism is relatively simple. But when I was using running years ago, and I've seen your cases that they are fantastic, but when I needed to adjust it, it was relatively common to have losing sutures because of the movement. So do you regularly adjust it, or you don't?
So my theory is that you only need to adjust the single sutures because you use single sutures, because you never get a regular astigmatism with single sutures, even you and me after 35 years of corneal surgery. So then you have to take out the very strong tension one. And with the double running sutures, we always use a placido disc at the end of the surgery, which is not exact, but I think if you see a round mirror, then it's okay. And the theory is when you see a little ellipse, then you have at least three diopters of astigmatism or more. And actually, I think over the last years, I did it once with a dull instrument at the slit lamp, just lifting a little bit through the epithelium in the steep axis, but actually I don't do it. And typically people see some have quite okay vision, not all of course, during sutures are in place, because we have very little suture tension, because due to the excimer laser trephination, the geometry is so fine horizontally and vertically that we can really release the suture tension to the least which is necessary to avoid steps. So in the end, I take the two sutures very strong, and then I put water in and make it up to 40-50 millimeters of mercury, and then I do the final
adjustment.
Yes.
Okay, so normally you take your time to adjust the double running at the end of the surgery, but in most cases, exceptionally, you need to adjust them post-operatively. You usually don't need to do that, no?
Maybe you would see a need, but I'm more tolerant to some maybe high astigmatism, 5-6 diopters. You know, if you talk to the patient and you say, well, after one and
okay,
regularize.
Okay.
Jose, I have a question for him.
Yes, of course.
Dr. Seitz, I was with Naumann when he was started with the excimer laser in Erlangen many years ago, and I did myself some penetrating keratoplasty with the masks of Gottfried. Why do you favor the use of excimer over the femtosecond laser for penetrating or lamellar keratoplasties?
this is my beloved topic, because if you have a keratoconus and
in keratoconus, I understand perfectly, but other cases.
But you know, you compress and
yes.
you get then you do the cutting and you never get a round opening, but you get a irregular pear-shaped or elliptical opening, and then you put the round button in, and so there is. When I did that in keratoconus, I had an astigmatism. I have on average 3 diopters with the excimer laser, and they had 7.5 after suture removal with the femtosecond laser, which was a disaster, also for my self-confidence, you know.
But in a macular dystrophy, for example.
Yeah, maybe that's better, and also the liquid interface device.
Yeah.
TEMA offers. We are now doing a prospective study, and I promised the CMAT company not to talk badly about the femtosecond laser if the prospective study gives the same results.
Okay.
Okay. Just to be fair, is 15 seconds left. So one final question, Mario. I am not aware of any report on rejection episode after a SLAC during SMILE lenticles. Are you? Because it is. I know that the stromal rejection is really uncommon, but not as uncommon because a SLAC, especially in India and in many other places, has been used so commonly. And without any, let's say, preparation of this tissue, but directly using it. So I am quite surprised not having had any single one, but perhaps I'm wrong. I don't know.
No, I think you're right. Actually, there are no reported episodes of rejection in the case of lenticle implantation of SLAC in the literature. And also, talking with colleagues in meetings worldwide, have no reported cases, which is fine. Actually, we can understand this because the quantity of stroma that we transplant with a lenticle implantation is much less than the quantity of stroma we transplant when performing a DALC, which is subtotal stromal transplantation. So it can be acceptable, at least in principle. One issue that is correlated, it's nice here to have vertical sides, is the fact that it is very different when you are using non-human stroma, because human stroma is very well accepted, also in terms of adaptation of the tissue and, of course, immune response. If you use porcine corneas, which is another option that has been proposed, Bertol, I think he was the one that reported a melting and so rejection with melting in case of those. So we need to keep in mind that human stroma is well tolerated when implanted intrastromally.
Okay. Jorge, it has been a pleasure to deal with that with you, but I think that you need to close the session. It's 32 right now.
Yeah, so we have to finish. So thank you to all. It has been a pleasure to have you with us. For us, it's an honor to have such speakers involved in our meeting. So thank you very much for your presence, and we're going to close the session, and we are continue in 15 minutes with our satellite session of biotech. Thank you very much.
Bye-bye.